Welcome to week 12, environmental safety, lifestyle management, and of course we will continue with our previous discussion, part 2. Many topics this week, very complex. So I will do my best to dedicate enough time to each component and subcomponent, starting from our first slide here, which is of course environmental safety. Let's begin by analyzing some basic concepts. When discussing healthcare environmental safety, we are focused on two main areas: internal and external environment and applied ergonomics. In the first case, environment, an example would be a nurturing and safe workplace and nature-respectful world around us. Okay, so this is what we mean by environment. And then applied ergonomics, i.e. safe patient handling, from ergon, which is Greek, of course, for work, and nomos, which is natural law. Okay, natural law as in the most appropriate nature-based, natural law-based way to work, way to interact. And this, of course, has to do with what we said in the previous weeks about posture, for instance. So let's see what risks are involved in inappropriate ergonomics. Manual patient handling risks, part 1. The physical demand of work, patient weight, shape, and behavior. Weight, of course, related to a heavy load that might be a problem in our own ability to move the patient. Shape, bulky and awkward, the way we are positioning the patient, and how sort of a grasp we have when moving in. And behavior, unpredictable, confused, fragile, and in pain. Okay? And of course, the physical demand of work also include a high repetition of tasks, which might be in themselves a problem, this time frame problem. Equipment and facility design, constricted workspace, and poorly maintained equipment. So we'll see that environment also means patient care from the perspective of setting. 2, poor work practices, adjustments on equipment, for instance, bed not used. All right, so not used because they might not work, or maybe because the healthcare provider is not aware of how to use it, or has not been informed on the new technologies implemented in a specific unit, for instance. Personal factors, job activities, for instance, lifting and handling children, trash, shopping, or performing yard work, etc., that might actually accumulate over time before the beginning of any given shift. So previous injury is also related to personal factors. Now, an important note here that I would like students to remember: using good body mechanics, remember we said about posture or in previous lectures, is not enough to prevent back injuries and other musculoskeletal disorders, MSDs. Please remember this term, caused by manual patient handling. So it's not enough, okay? It's a very good start, but it's not enough. Risk 3, the physical effort required to repeatedly lift and move patients manually is greater than your musculoskeletal system can tolerate. So as you can see here on your spinal cord, you have compression, rotation, and showing on the bottom. The arrows show direction of load or force on lower back, L5S1, when manually lifting and moving patients. Now, a definition of MSDs. MSDs affect ligaments, muscles, tendons, cartilage, blood vessels, and nerves, and spinal discs. Acute MSDs, a sudden or one-time traumatic event or incident, for instance, slip, trip, fall, or car wreck. Chronic or cumulative musculoskeletal disorders, injuries that occur over a period of time, months through years, and are caused by a combination of risk factors. So similarly to what we said about chronic stress, it is important to understand that there is a cumulative effect in these type of disorders. Now, some common MSDs: strains and sprains, neck, back, shoulders, low back pain, and sciatic nerve, right? Bulging or herniated spinal disc, carpal tunnel syndrome, tendinitis and tenosynovitis, upper extremities, epicondylitis, tennis elbow, golfer's elbow, rotator cuff tear, extremely common, especially in nursing practice, affecting shoulders, bursitis, shoulders or knees. Now, some risk factor here. On the right side, you have a little picture indicating common musculoskeletal disorders as in the previous slide, and then the 3 factors with time that are essential in the development of MSD. So force, awkward and static postures, and repetition. Inappropriate awkward posture and MSDs, Part 1. Definition: position of the body when performing physical tasks. Awkward postures cause biomedical stress to joint and surrounding soft tissues. Strength to the body part is decreased, accelerating muscle fatigue and increasing risk of injury. Awkward postures include, there's a picture here and another one in the next slide, bending, twisting, reaching overhead, kneeling, squatting, and pinch grips. You see here a comparison between neutral posture and awkward posture. More specifically, back flexion, back extension, twisting about waist, and lateral bending. You probably are all familiar with this if you had a chance to work in healthcare facilities before. Static or fixed postures and MSDs. Definition: postures or work positions that are held for a period of time. Okay? You can see this image here, neutral posture versus awkward posture. Examples: prolonged standing or sitting, performing patient care tasks or making a bed while bending forward the waist for a few minutes or longer, supporting a patient's extremities or heavy instruments during a nursing task or medical procedure. Blood supply reduced to muscle involves muscle fatigue. Another element based on the previously viewed triangle, force and MSDs, Part 1. Definition: amount of physical exertion or muscular effort extended when performing a task or activity such as lifting, pushing, pulling, carrying, or gripping tools or equipment. Keep in mind that the greater the force exerted and or sustained over time accelerates muscle fatigue and increases risk of injury. 2. The amount of force exerted is influenced by the weight, shape, and condition of the patient or equipment, by the body posture used, by the numbers of repetitions performed, and the duration or length of time that the task is performed. Examples here, I'm sure you're very familiar with this. Load or patient shift suddenly or unexpectedly, lifting bariatric or obese patients, pushing a stretcher with poorly maintained or incorrect casters. We talked about effects over time. So let's analyze this, the cumulative effect, Part 1. Duration of exposure to risk factors. This is affected by working through breaks. It's very, very important to take a break. Overtime and task variability. Again, this is especially true for nursing staff and physicians as well. We had to put patients at the central intervention, but we also need to find time for self-care. Okay? Otherwise, the patient will be negatively affected. Nota bene, so it's important, when the musculoskeletal system is exposed to a combination of these risk factors too quickly, too often, and for too long, without sufficient recovery rest time, damage occurs. Okay? So it might not be immediately visible, but it plays a very negative role over time. This is an image of what we mean by that, the cumulative effect. On one side, you see continued exposure to risk factor, and on the other side, of course, you see time. Now, see the development of this cumulative effect. You have fatigue, discomfort turns into pain, pain creates injury, and injury eventually turns into disability. Healthcare ergonomics. To continue the conversation we had in the previous weeks, the science of fitting the physical and cognitive demands of the job to the worker to prevent injury, human error, and improve worker and patient comfort. Classic quote here: fitting the job to the worker, not fitting the person to the job. Now, of course, there are, we should meet in between when we talk about attitude, culture in the workplace, but we're talking about safety here. So to match and balance, as the image implies here, capabilities of people and demands of the job. Capabilities of people that might be actually changing over time. So whether a nurse, for instance, might decide to change his or her role in the same unit or move to a different unit, for instance, and work on different aspects of nursing itself within the same scope of practice. Preventing MSDs, what can we do about it? The second choice, rather than focusing on everything we said so far, which is focusing on good posture, good ergonomics, practice insightful strategies, having control or on one's movement, the second choice is work practice controls. Remember, whatever your job might be, all right, it's the employee's responsibility to use good work practices and follow the organization's safe patient handling policy and procedures. Reduce employee exposure to primary risk factors by using best work methods. For instance, plan work organization, use good housekeeping practices, use adjustments on equipment, get help, eliminate unnecessary movement, and do not use broken equipment. This is similar to what any fitness or environment or gym would tell you, right? So it's important to put our safety first. Second choice, again, work practice controls, use neutral or good body postures. Neutral postures reduce physical stress on musculoskeletal structures and enable optimum blood flow to the musculoskeletal system. Your body is in the strongest and most balanced position. And here we have an image with some basic office stretching. The image here says, stretching should be performed slowly without bouncing or jerking. As you stretch, the tension should begin to ease. After this, you can gently begin to increase the stretch. That's a few things that we can do to prevent further injury. Administrative controls. Reduce employee exposure to primary risk factors. For instance, ergonomic training, policies and procedures that define good work practices, job rotation, staffing, and overtime practices. Now, on the left side of this slide, you can see a combination of three main factors, all which contribute to the reduction of the risk of injury for employees and patients. So it's important to understand that this is important for both sides of the spectrum, both sides of the equation, okay, for us and for the people we are taking care of. So engineering plus work practice plus administrative controls. In this image here, you have a desktop visual description of the extension that might be contributing to the problem. Easy in green, awkward in yellow, and to avoid in red. Okay. Now, of course, you might see this picture and see that there's nothing incredibly dangerous or damaging at first, but again, keep in mind that there is indeed a cumulative effect over time. Now, let's continue with the next slide. Neutral standing posture. So you see good posture on the left-hand side in blue and bad posture in red with forward head and anterior pelvic tilt, which is very often a result of malpractice from our own perspective as well as use in the context of a moving patient, for instance. Neutral posture for work performed in a standing position. Stand with feet shoulder width apart, knees are flexed, unlocked, extremely important, head upright, shoulders are relaxed, not roll forward. And this, of course, has a lot to do with psychological factors too. It's not that we are performing tasks in the wrong way, and that's the only reason why our posture is not good. It can be a result of psychological factors. For instance, the way we are, metaphorically speaking, open to the world. The chest opens up and the shoulders are relaxed, as opposed as we are in a defensive modality in which we are kind of trying to control and we're kind of cocooned onto ourselves, right? So chest up, back straight, elbows not locked or flexed more than 110 degrees, wrists straight, ears, shoulders, hips, knees, and ankles should be in straight alignment to maintain a natural S curve of the spine, which, as you can see here, is equivalent, synonymous with a neutral position, okay? Again, we're not talking about normal position necessarily because there are some, variability, but neutral as in not affected in one or the opposite direction. All right, so what can we do about it in practice? This is the last slide for this part of our lecture. Conducting a hazard or risk assessment to reduce risk of musculoskeletal disorders. First, assess the patient. 2, assess and prepare the environment, even before you do anything, right? 3, get necessary equipment and help if needed. Finally, only after all of this, perform the patient care test, lift or movement safely, right? It is really important to pay attention to each of these steps. Wonderful. Well, thank you very much. We will move on to the second part of this lecture, which is lifestyle management. Now, lifestyle management, of course, involves a lot of different approaches and subfields, from nutrition to exercise, work-life balance to empowerment, etc., etc. So for this course, I want to focus on two specific areas, all right? So we're talking about nursing as a profession, as we're talking about health coaching or health and wellness coaching. What is health and wellness coaching? Well, first of all, health coaching can be this very broad and somewhat vague term that someone might interpret as similar to counseling, for instance, within a psychological, psychotherapeutic perspective, or in the context of sports, for instance, and lifestyle in general. The way we interpret health coaching here is the way defined and administered by the National Board of Health and Wellness Coaches, okay, to become an NBCHWC, so the National Board Certified Health and Wellness Coach, okay? And for nursing, of course, we intend nursing as in a registered nurse profession. So using these two modalities, we'll see what each of these professions can provide to an appropriate healthcare lifestyle management. Utilize the nursing process to construct an individualized plan of care for a patient based on critical analysis of patient assessment data, similar to what we said earlier, right? Nursing process, systematic method of giving humanistic care that focuses on achieving outcomes in a cost-effective manner. Again, systematic in terms of considering all the components, as we previously discussed in other lectures, and humanistic as human-centered, patient-centered, not necessarily humanistic in a socio-political, philosophical perspective. Cost-effective manner in terms of analyzing each step to make sure that our care matches the best possible approach. All right, so let's dig a little deeper in this concept. Nursing care plans, what do they involve? Written guidelines for client or patient care. They're organized so the nurse can quickly identify nursing action to be delivered. And this is something that has to be part of a constant amelioration, can be a qualitative and quantitative improvement study, right? Unit improvement study. Coordinates resources for care, enhances the continuity of care. It's extremely important to avoid mistakes, to avoid injury, and to provide support. And finally, organize information for change of shift report, okay? What is important in healthcare is not just what happens during the treatment, during the analysis, during the assessment, during the care we provide, but also in between, to make sure that the care is continuous, that there's no mistakes or breaks in between, right? Of course, we're not talking about breaks within a shift. We already mentioned how important they are in order to prevent injury and also to keep the focus, but breaks in turn break in the chain of communication. Putting it all together in this nursing care perspective, assessment is the first step in determining a patient's health status. Put pieces of the health together, and the entire plan is based on the data you collect. Data needs to be complete and accurate. We mentioned this before. Your intervention, your examination, your analysis is important in the broader context of the multidisciplinary treatment team. Collect, verify, organize data, identify patterns, physical, cognitive, etc., report and record the data, and finally report significant abnormality immediately. Cluster data into groups according to a nursing or medical model. Now, as an example here, I quote again the Maslowian from Abraham Maslow, the basic human needs model, the pyramid of needs. So what are the priorities from the patient perspective? So you can definitely see here how medical philosophy is combined with nursing practice. Clustering data helps maintain a nursing focus, allows patterns to be recognized. Need deficits, so you can come to the problem from both ends. What can we analyze? Each body system, each part of the system, and we analyze the balance as well as the problems in each system, and what is still missing or what is out of balance from the homeostatic standpoint. Helps to identify nursing diagnosis pertinent to your client. Okay, so your patient is a person, is a client, is a specific individual. Example, all information gathered regarding nutritional status may help to identify nutritional alterations. So you have biostatistical evidence-based science about nutrition in general, and then you need to utilize that broad knowledge and translate that into the needs and presentation of the specific patient you're working with. Now, fundamental principles of diagnostic reasoning. This is, again, connected to medical philosophy, but specifically for the nursing profession. Recognize diagnosis. Keep an open mind, meaning you might miss something you're not yet aware, right? And again, the client is an expert in their own well-being too. Back up diagnosis with evidence, so do not infer things that are not scientifically accurate. Intuition, however, I really want to stress this, intuition is a valuable tool for problem identification. And to some extent, this is where the strength of nursing as a profession plays a major role, even in comparison to other disciplines such as the profession of a physician or a psychologist, okay? Intuition is really important, and it's developed over time. We have to be independent thinkers, of course, on the basis of the broader picture, but also the ability to detect possible mistakes that previous assessments had within themselves, and then know your qualification limitation, which is another term to say we have to always operate within the scope of practice of our profession. We might certainly bring some ideas to the interdisciplinary treatment team, but we cannot infer any assessment or diagnosis if this is outside of the scope of practice or outside our training, simply put. Wonderful. Some examples here. We want to make sure that this conversation, this discussion is not just theoretical. Let's talk about just a few areas here. We don't mean to summarize all the professions in healthcare, but at least three elements that we should keep in mind. Three areas. One will be physical activity, one will be nutrition, and another one will be addiction and recovery. Okay, so these broad areas. Start with the first one: physical activity, appropriate recommendation applications. Now, the person, the patient, the client might come to you and really have no idea what is balanced, appropriate, standard, baseline activity, physical activity. They might not know whether exercising once a year is enough, whether exercising 3 times a day is normal. They might not know where to start. So it's a good idea to have some solid knowledge of overall general recommendation. Now, in the context of this lecture, I only want to mention very basic things, and based on what we said in week 3 and 4, you should already have a sound grasp of where to find resources to make sure that you have information that's very updated based on the current peer-reviewed scientific publication. This is just an example. How much activity, physical activity, do I need? You can see here, moderate intensity aerobic activity, anything that gets your heart beating faster counts. At least 150 minutes a week of moderate intensity aerobic activity, plus, see the and in between, muscle strengthening activity. Do activities that makes your muscle work harder than usual at least 2 days a week. Break it up over the whole week however you want. Now, of course, these are general recommendations, and I cannot stress enough the importance of making sure that we know our patient extremely well in order to avoid possible injuries. Because when we say baseline normal, we do not mean that this is safe for everybody. We always need to make sure we have a solid knowledge of what's in the H&P and all the clinical notes upon the admission in any hospital, in any unit, in any clinic. Wonderful. So let's continue the second part of good examples and information. Appropriate nutrition. Know the science and reject misinformation. Now, in this lecture, I will not venture into specific dietary recommendations for the same reason as we previously mentioned that it is a proper practice to know the basics, be focused on current scientific evidence. I will provide some of the resources in this week module, but at least know the generic. Now, in this slide might be a little confusing to you because, first of all, it's written in Italian, it's not in English. And aside from my own bias, being a European person, very often one of the standard recommendation in medicine, in healthcare, is to follow a Mediterranean diet, okay? Now, I want to acknowledge this, that first of all, there are cultural factors that are extremely important, ethno-cultural factors, ethno-religious factors as well, within dietary prescription, a combination of foods that we ought to reject on philosophical, religious basis as well. So when we talk about a diet, we should always keep in mind that there are certain elements that stem from culture, religion, upbringing, etc., right? And this is definitely true for a situation where a vegetarian or vegan diet or an omnivore diet, etc., are at the center of our investigation. But since we talked about Mediterranean diet, all right, an example is this is not to say that the Mediterranean diet is probably not true as being one of the healthiest, if not the healthiest diet that is effective, useful, safe, and nurturing for all patients. This is definitely true, and there's plenty of scientific evidence to demonstrate that the Mediterranean diet is really one of the best diets that we have in medicine. But of course, when we talk about Mediterranean diet, one of the issues is to understand what we mean by Mediterranean. We need to understand that Mediterranean, just as any other cultural, geocultural, geographic term, is focused on a specific area of the world, and our own interpretation in the West, okay, outside of the Mediterranean, especially in our case in the United States, might be actually a misinformed, stereotypical, sometimes a caricature-like description of what Mediterranean diet is. So my advice in this specific context is to ask the cultures that are indeed Mediterranean. So searching information, at least written in the languages of the areas, the countries in the Mediterranean. So I have the ability to read scientific papers written in Greek, for instance, or in Italian, or in Arabic, for instance, would be a good idea, right? Now, of course, within the Italian culture, since Italy plays such a fundamental role in history, particularly when it comes to nutrition, that's the choice that I made here, to present a pyramid of proper nutritional values based on the Mediterranean diet, right? Now, on the bottom, you see attività fisica, which simply indicates physical activity as a primary factor in combination nutrition. So this means that whatever we are eating, it is important to have a proper physical activity to help our digestive process. This is essential, right? Now, on the right side, you see consumo mensile, which is monthly intake. In yellow at the center, consumo settimanale, which is weekly intake. And then finally, in green, the food that we should eat the most, consumo giornaliero, daily intake, okay? And on the other side, you have, the from the dark green, at least 5 portions every day, all the way to just very small portions in red, okay? And it's a grading here, it's a scale. Now, when we talk about reject misinformation and fake science, pseudoscience, we mean just that. For instance, you see that one of the most recommended food, aside from greens and fruits, are pizzas, all right? And this is something that personally I found quite very interesting, that outside the United States, pizza is very often recommended by nutritionists, physicians, etc., as one of the most important food types to consume possibly every day, okay? And versus the United States, pizza, for a reason that really escapes me, is considered to be not a healthy food. Now, the science is pretty clear, okay? And of course, pizza has also a component of culture associated to it, and it's an anthropological component. So for instance, in the Mediterranean diet, the very presence of tomatoes is something that is a really recent event in the last 500 years or so, coming from the Americas. And so whether considering tomato and tomato sauce as part of the Mediterranean diet, it's definitely true, but we should also keep in mind that from the perspective of evolutionary biology and gastrointestinal processes, it's a really recent addendum to this type of a diet. And yet you find equivalent pretty much throughout the Mediterranean, right? You might find, types of pizza like pita or flatbread types throughout the Mediterranean. So it's definitely a common practice to eat it, right? And even similar preparations such as the naan bread have a lot of commonalities with pizza. So one thing to keep in mind, and this is just an example, of course, okay, talk about dairy products that are also viewed somewhat in a negative sense, or carbohydrates that in the United States are considered somewhat problematic in comparison to protein intake. This is definitely not true outside the United States. It's definitely not backed by science. So this is simply to say that we have to have a solid scientific knowledge and reject misinformation. Okay, so please, make sure that you eat healthy and include pizza in your meal. Of course, when we mean pizza, we don't mean pizzas as delivered by fast food chain industries. This calling those products pizzas, it's almost an insult to the Mediterranean diet. But again, I really encourage students to investigate these things further. This is also an example that, from my own perspective, clinically speaking, as a psychologist, plays an essential role in discussing possible psychological issues related to food and the food industry, right? Particularly in the context of dietary problems, of eating disorders, etc., etc. We have to make sure that we have this holistic approach to food, which has to be approached from a mindful perspective. So chewing slower, eating smaller portions, taking time. Eating is a ritual, okay? We should make time for ourselves when we eat. And food should be somewhat of a sacred ritual as well. It should not be consumed in the context of anxiety or having a short breaks. And of course, this has also to do with some recommendation that we ought to do toward healthcare in general, to make sure that the nurses, for instance, have enough of a break between shifts, so they don't have to speed up, in chewing and swallowing amount of food that will require a much longer time to be properly digested, starting with Thailand in your mouth. So those are just some examples of making sure that we have solid scientific knowledge and that we approach nutrition also from a holistic and well-informed point of view. The next part, and the last part for good examples of information, is addiction and recovery. Now, we can talk about addiction and recovery from a variety of perspectives, but in healthcare, health-damaging behaviors are extremely important. Poor coping mechanism, hazardous behaviors, and addictions, insights and solutions. This is just a brief example of the trans-theoretical model of change, or the stages of change model by Prochaska and Di Clemente, that focuses on a non-blaming, non-judgmental view of addiction. And it's a model that can be applicable to any type of addictive behavior, from alcohol and drugs to pretty much everything. The idea here is that you have different stages, all of which is connected to the next one and the previous one. So rather than thinking of addiction in a linear line type of process where you're either sober or quote unquote clean, and then if you relapse, you go back to stage one, you have to start from scratch. This is a cycle. Okay, the cycle is pre-contemplation, contemplation, preparation, action, maintenance, and relapse is indeed a possible stage. All right. Now, inside this little diagram, you see upward spiral, learn from each relapse. So relapse is also insight caring. Okay, it's a new lesson. It's not recommended, of course, but it's in itself a part of a process. So let's take a look here. So relapse, of course, fall back into old patterns of behavior. Pre-contemplation. If a person is in a pre-contemplation stage or phase, there's no intention of changing behavior. There might not be awareness of there's anything to do about it. Contemplation instead defines the fact that we are aware that a problem exists. However, there is no commitment to action. In preparation, there is an intent about taking action, but no action yet, because action, as the name implies, is the next stage, an active modification of behavior. Finally, what keeps us healthy is maintenance. So sustained change, an important factor, new behavior replaces old. These are important elements in healthcare in general. When we are examining better coping mechanisms, better behavioral models, it's not about blaming, labeling, and trying to repress or remove problems. It's about substituting something that was not good, and by good we could also mean not as effective or potentially dangerous, with something that is good, effective, and nurturing. Okay, so again, let's restate this. There's a change that is predicted upon a new balance, a new behavior replacing an old one. This is essential in the context of motivational interviewing, for instance. We talked about this before. Motivation interviewing as a practice focuses on the client, the patient, as the client, the patient is their own expert. And this is a model by Milner and Rolnick, for the ones of you who would like to discuss this further. And it's a practice that similar to this trans-theoretical model can be applicable to nursing, to medicine, to psychology, to counseling, to health and wellness coaching, etc., etc. It's a very patient-centered approach and focus on four main areas. I did not mention it in this slideshow, but just to provide further information here, think of this acronym OARS, O-A-R-S, where O stands for open-ended question, A means affirmation, positive affirmation, R stands for responses, and responses as in reflections, depending which model you follow. So reflecting back to what the client has said, okay, and S for enhanced reflection, so a summary, right? So OARS, OARS. Wonderful. So this is the third part for good examples and information. When we talk about this model, the trans-theoretical model of change, and when we talk about motivation interviewing, we also talk about goals. We need to inform our patients, and by inform, again, we mean to shape a more insightful sense of self so that they are better equipped to take care of themselves and in turn produce a better health result overall, taking care of their own well-being. And we talk about goals, right? So what do we mean by goals? Well, a good way to begin our analysis is to define short-term versus long-term goals. So short-term goal can be achieved in a reasonable amount of time, a few hours to a few days, as an example, versus long-term goals may take weeks and months to be achieved. It's really important from the perspective of healthcare. For instance, the client will ambulate down the hall within 2 days. The client will walk the length of the hallway independently by the end of 2 weeks, all right? And so, again, this is extremely important when we talk about documentation and clinical notes, SOAP notes, to make sure that each shift, the nursing staff, the healthcare team members present during that shift, they should all be aware of what's going on at any given time and what to expect in the near future. Now, achieving goals and outcomes. Be realistic in setting goals. Look at overall health states, growth and development level, prognosis. Set goals mutually with the client. Again, this is important because we are not prone to achieve a goal unless our client, our patient, is there with us, all right? Otherwise, upon discharge, the client will not follow up, and it's really detrimental for well-being. Goals should be measurable and use measurable and observable verbs, okay? A proper jargon, appropriate way to quantify the term, okay? Not vague statements. Identify one behavior per outcome, okay? So very, pretty much the same perspective that we utilize in the scientific method, right? The principle of falsifiability, making sure that we account for one variable at a time, right? Each variable for its own analysis. And then when indicated, use short-term versus long-term goals. Evaluations of goal achievement. So when do we know that this is actually when can we say, okay, we did a good job, the health outcome has been obtained? Measures and sources, assessment skills and techniques. As goals are evaluated, adjustments of the care plan are made. If the goals was met, then part of the care plan is discontinued. Okay, and that's important for the updated clinical note, which sometimes happens once a week in terms of the overall treatment plan update, but of course, as part of the clinical rounds happens on a daily basis, and then redefines priorities, which can be adjusted depending on the new, improved, hopefully, health state, but also in the case of possible issues and problems. Now, in this image here, it's a precursor to the next slide, which will focus on SMART goals. This is the integrative healthcare, healthy lifestyle, wheel of health. And this was specifically from the University of Vermont Integrative Health. So making sure that when we talk about goals, we take into account this holistic perspective. Now, of course, mind and body and movement are extremely important because we're talking about health and medicine, and so is nutrition, and so is environment. But we should also make room for relationships, personal development, spirituality, sleep and rest, so sleeping patterns, and of course, work-life balance. We talked about that quite in depth when we mentioned ergonomics, of course, that everything can be affecting the way we are interacting with our patient, but also work-life balance in terms of purpose and meaning and structure and expectations, as well as psychological well-being overall, okay? And also make sure that we are not overworked so that we might actually make more clinical mistakes in this situation. So this is just a suggestion, a wheel of health. Now, we talk about SMART goals. What are SMART goals? Well, SMART goals are specific, measurable, assignable, realistic, and time-related goals. It's a way to define goals in a way that makes sense from the perspective of healthcare, at least, okay? Specific, target a specific area for improvement, okay? What is your goal? I want to work on my nutrition, right? Measurable, quantify, or at least suggest an indicator point. So how do you know that you exercise enough? Well, if I can exercise for at least 2 days a week, that is a progress, okay? Assignable, specify who will do it, especially when there are somewhat vague goals. Well, I'll work on my work-life balance. Okay, so what are you going to do about it? We don't talk about your work environment, you're talking about your team, your boss, or it's something that you can address. Realistic, stable results can realistically be achieved given available resources. Again, this has to be focused on what is achievable in the moment. For instance, after a fall, what is a realistic goal? Can the patient go back to perform in, I don't know, in a high demanding profession, a sport, for instance? Can they go and run as if nothing happened? What is the expectation? And for this expectation, in turn, is related to time. So time-related goals specify when the results can be achieved and having a good timeline. Wonderful. We have like 2 more slides. Now, some theoretical basis when we talk about goal-setting theory in the context of healthcare. Goal-setting theory highlights the importance of goal setting by proposing that those who set goals for themselves are more likely to achieve success than those who not. Again, let's repeat this. Those who set goals for themselves, empowered, right, are more likely to achieve success than those who do not. Okay, so shifting from giving advice to eliciting advice. Researcher Edmund Locke was instrumental in proving goal setting theory to be true, and he proposed 5 principles of effective goal setting. So let's take a look at these 5 principles to conclude this lecture. The 5 principles of goal setting theory are: clarity, goals need to be clear and easily understood in order for them to be most effective. Challenge, good goals have a high enough level of difficulty you can actually have to push yourself in order to achieve them. This is intrinsic motivator. Commitment, without a high level of commitment, it's difficult to achieve any goal, especially those that are somewhat challenging. Okay, and they can also make more fun. And the last 2, feedback. You need to be able to receive information about how well you're progressing toward your goal. This information can be used as a motivator, or it may signal that your goal is either too easy or too challenging and needs to be adjusted. Finally, test complexity. The more complex a goal is, the more time you need to give yourself to achieve it. Good goals don't have to be complex, but understanding how complex your goals are is an important part of planning how you will achieve them. Thank you again for your attention to the topics of week 12. I appreciate, and I will see you all next time.